Hi. Okay, so now we're going to discuss Chapter 8, which has to do with safety, which is a huge, important issue. It's fundamental to patient care needs, and we're going to discuss developing a culture of safety. So, elements of a culture of safety in an organization are established um, as a priority, an organizational priority, and it's going to emphasize teamwork, patient involvement, openness and transparency, so discussing when errors happen or risks, and then accountability. So those are the shared core values and goals. Non-punitive responses to adverse events are certainly important as well. And you need to promote safety through education and training. And obviously, the more supportive you are from the top down, the more of a just culture you're going to have. So a patient safety culture should be non-punitive, emphasize accountability, excellence, honesty, integrity, mutual respect. Now, obviously, sorry, hold on a second. Obviously, a culture of non-punitive is different from a culture of obviously keeping people accountable and not being neglectful. So it incorporates safety principles such as designing jobs and working conditions that are safe, standardizing and simplifying equipment and training people, making sure that supplies and processes are also simple and standardized, and avoid reliance on memory. Because if you have to remember everything, you're going to forget it. To err is human, remember that. So you need strong, committed leaders, engagement and empowerment through employees, and you need periodic assessment of your culture. So I want to show you guys the AHRQ website on safety. So we're going to go there. This is a really good ahrq.gov/quality/patient safety culture. It pops up here. All right. So AHRQ, healthcare associated infection programs. All right. So here's everything that, they talk about patient and safety. These are tips for preventing medical errors, promoting patient safety, measuring healthcare quality, consumer assessment of health plans, and evaluation software, report tools, and case studies. So it talks about improving diagnostic safety. So diagnostic error is significant and under-recognized threat. So not just med errors, but are we diagnosing things safely? Are we hemolyzing the blood? And so we're assuming someone has high potassium and treating it thus so. What about reducing hospital-acquired conditions? This is the goal of Partnership for Patients, a public-private partnership working to improve quality, safety, and affordability in the healthcare. So let's take a look here. All right, so reducing hospital-acquired conditions. This is the goal of Partnership for Patients. It's a public-private partnership. Includes AHRQ, we talked about CMS, and others that work to improve quality and safety. So hospital-acquired conditions, so nosocomial infections, nosocomial issues, they're conditions that develop while they're in the hospital. So DVTs, infections, wounds, and there are tools to discuss that. So first, let's look at the National Scorecard. All right, so the National Scorecard on Rates of Hospital-Acquired Conditions is a report. So let's take a look. All right, so let's see. The National Scorecard of Overall Hospital-Acquired Conditions is going down. Great. This is showing about the changes, the total annual reductions. Catheter-associated UTIs, 15.2% change in HACs. So that's really good. So let's look at the toolkits that this place offers. Okay, so adverse drug reactions. Okay, medications at transition and clinical handoff. Medical reconciliation. That's so important, right? So medical reconciliation is a complex process that impacts all patients as they move through the healthcare setting. So if you go from the OR to med-surg to the ICU, how do we identify discrepancies with medications? The toolkit incorporates the experiences and lessons learned by healthcare facilities. All right, so let's look at this. So look, it talks about here's a review of literature, which is important. Resource justification. Okay, so how do we justify a project? It might cost a lot of money. So most healthcare facilities today are operating with limited resources, including financial staffing limitation. A project that helps to identify roles, responsibilities, and staff resources is needed. Okay, so financial model for medication reconciliation is talking about how much they would save if you had proper medication reconciliation. Okay. So it talks about core measures, meaningful use in the EHR, reducing readmission. All right, so let's see, developing a change, designing a med reconciliation process. All right, so wait, before we looked at the review of lit, a team was formed. We're not going to get into that. But let's look at their project design, okay? All right, so the essential principles, okay? You develop a single med list, one source of truth. Clearly define the roles and responsibility. Who is reconciling where and when? Standardize and simplify the medication reconciliation process. Will it always be done at admission? You want to eliminate unnecessary redundancies. Use a flow sheet. Make the right thing to do the easiest thing to do. That's really important. Develop effective prompts in your EMR. Educate patients and their families on med reconciliation. So empower the families, center the patient and family-centered care so that they understand what they're getting, so they can say, I don't think I'm taking that anymore. That should give pause to whoever's going to administer something to say, let me double check. And I do that all the time. I don't think I'm supposed to be taking that lisinopril, Denise. Okay, you know what? Let's double check. You're right. It wasn't discontinued on your main med list, but it was discontinued when you saw the nephrologist last week because you're in renal failure. Imagine if I restarted that person's ACE inhibitor, okay? Ensure process design meets all pertinent local laws. And that just goes through all the different things. Developing a pilot. So this talks about how you're going to implement the change. Education training, how you're going to assess things, process evaluation, okay? What auditing tool are you going to use? This is really important stuff. So this just shows you a little bit about AHRQ and their safety quality, okay? Here's some comprehensive unit-based safety programs, eliminating safety and errors and addressing safety issues. Here's let's look at the success stories. Okay, let's talk about the vascular access team, shall we? All right, so Erin Saul is a nurse, highly regarded in the ICU, and began inserting PICC lines, okay? And based on literature review, connections with other innovators and his own experience, began augmenting the CLAB-SI elimination bundle. So that's for infection. He added detail on insertion and maintenance, including following up on line hubs, cleanings, and frequency of dressing changes. And he drew from all the information out there, existing literature, and made his own bundle. And he began to develop criteria for selecting the most appropriate line to best meet the patient's needs. And he was able to lower PICC line complications and infections. So you're probably like, okay, all right, that's great. You showed me a bunch of things. So what do you need to know about safety? So you need to understand that safe, effective delivery of patient care requires understanding of the complexity of your care delivery system, that humans will make mistakes. What are principles of safety design and characteristics of highly reliable organizations and patient safety resources? So patient-centered care, this ensures that the family and the patient is in the center of decision-making process because they're another person or group that can hold you accountable. They understand the plan of care that can prevent errors from occurring. So if they know exactly what's supposed to be happening, again, they can hold the team accountable. Evidence-based practice, this ensures that you're using the most up-to-date science. Okay, why are we still doing wet-to-dry dresses when the most evidence-based science dissuades this use? Because it's a protected practice? Great, but we shouldn't use it anymore. Teamwork and collaboration. This ensures the healthcare team is communicating and working together effectively. So learning how to talk to each other and communicate without the fear or the stigma, oh, he's mean because he's a doctor. Well, you don't know that. Doctors can be nice. They might need to learn how to communicate, especially the older docs. You need to learn how to communicate and be straightforward. And that's important so you can collaborate for a team to say, hey, this is wrong, or not wrong. Hey, this might not be the best way to do it. Let me show you another way. And then quality improvement. So always looking at analysis, always looking at benchmarks. How can we be better? So categories of error. There are a lot of different categories of error. Sometimes there's something called latent failure, also known as the blunt end, and that arises from decisions that affect organization policy, procedure, and allocation of resources. So for example, a group made a decision to purchase, purchasing made a decision regarding the type of monitoring equipment to buy, okay, without the input of a nurse. So we're going to use this type of SpO2. And there's lots of failure with it. It doesn't really read well. It doesn't compute into the EMR. And so the nurse will be interrupted in their medication administration because they're trying to fix this faulty machine. And this can also be referred to as sharp end. So the system failures or indirect failures that relate to the management of taking care of a patient. So making care safer. So understanding how to make care safer. There's user-centered design, and that makes it easier for the clinician to do the right action. Avoid reliance on memory. So standardizing and simplifying procedures will decrease the demand on memory, planning, and problem solving, because when you are busy and you're seeing a ton of patients, it's not because they don't think clinicians are smart or nurses aren't smart, but you're going to forget things. Simplifying processes minimizes the problem solving so you can save that for the real issues. Attend to work safety, so work hours, workload, staffing ratios, distractions, interruptions. So you're getting interrupted because you have a faulty pulse ox monitor and you're going to lose your concentration. Having to chart something outside the room and then you forget half of what you need to chart, and that affects the patient later on down the road. Standardizing practice with implementation of red rules or sacred spaces are practices that attend to a safe work environment. So avoid reliance on vigilance. So checklists, well-designed alarms, rotating staff, and breaks decrease the need for remaining vigilant for long periods, because you're just going to tire out, and eventually you're going to have more, you're going to have fatigue on alarms, and you're not going to catch things. We've talked about involving patients in their care, training concepts for teams. So team collaboration is important. So training for that is important, being able to talk to each other, anticipating the unexpected and knowing what to do with it, designing for recovery when something happens, and improving access to accurate, timely information.